So good morning, everyone. That's many thanks for the invitation. That's with pleasure and honor to be here. And let's present my lecture, who is delegate to angiogenesis markers. I concentrate on the two angiogenesis markers, FLEET and PLGF, and mostly, I think so, the most valuable we look on the what's going on in the scientific world, the PLGF, this means the placental growth factor. So that's what's the most important information. Last year, the very high top level society classified the new preeclampsia diagnosis and look at this, include the angiogenetic imbalance to the diagnosis of preeclampsia. This means that they're very valuable markers to present and to diagnose this status during the pregnancy. Of course, everything well known that's prepared by Professor Nicolaides and his team, the ASPRE trial, which allowed to predict and implement the prophylaxis with aspirin in the high-risk group, the pregnant woman who can develop in the second part of the pregnancy the preeclampsia. And of course, we should know the cutoffs. The situation slowly changed. We have the couple of players. One of this is the Perkin-Elmer, and we are working on the Delphia Express, and they have their own cutoffs for the PLGF. When we talk about the normal range, this is above the 150 picogram, the low and very low. That's also very important cutoffs for these markers. And that's, of course, more potential, a little more expensive tool, this FLEET PLGF ratio. They have also own cutoffs for the Delphia. They are slightly different for the Roche Diagnostic or the other companies. So I start how we use this method and these biomarkers in the first trimester and prevention. Of course, there are also many scientific manuscripts who show how important is the screening preeclampsia. And look at this, that's Professor Shenzai Tong presented how important is, especially for the Caucasian people, how predictable is the preterm preeclampsia if we use the triple test. Triple test, this means using the uterine arteries Doppler, mean arterial pressure, and exactly PLGF. And if we would like to predict all preeclampsia before 32nd week of pregnancy, and we use exactly this triple test, we can predict more than 90% of the cases. That's a totally new approach, which we should use in every patient. So we evaluate and we use these tools many years, and we observe that's very important what kind of cutoff we use, and another one, what kind of the biomarker we use. This is one of our manuscripts, and we included almost 2,000 patients and present and compare the prediction of the preeclampsia and also prediction and the number of the high-risk group according to using the PLGF or PAPE. And if we use and then we describe the high-risk group as preeclampsia higher than 1 to 100 and use PAPE, that's almost the same. If we use another one cutoff, 1 to 150, this also almost the same. But if you look on the together preeclampsia and FGR, the situation changed. This means the PLGF increased the number of the high-risk group. Another one situation, almost 20% women we include to the high-risk group if we concentrate together on the preeclampsia and fetal growth restriction. That's why we strongly recommend create the high-risk group only on the preeclampsia. And another one situation, if we compare the cohort, the population, the situation change if we use PAPE and if we use the PLGF. PLGF, that's allowed to describe slightly different population. And this difference between the PAPE and PLGF reach almost 1/4 of the population. 27% was different. That's why, and if we look on the final results, the precision of the prediction, the PLGF is more valuable in the prediction of the preeclampsia. Another one, our manuscripts show that we can use the slit PLGF ratio to use to surveillance or to prediction of the small babies. That's the look at this one. That's many different presentation of the placental insufficiency, and we see that this slit PLGF ratio is abnormal in these cases, but it's also abnormal if we have the small babies without any other symptoms of the preeclampsia. This means this also we observe the placental insufficiency in some of these cases. And it's of course what is the more potential for the our surveillance of the pregnancy and our care about the pregnancy is using these markers as the prediction of the perinatal outcome. And we see the value of these markers allow us to predict bad or the good prognosis for the pregnancy. And we show that if we have the no disturbance in the angiogenesis markers, the so important factors like fetal weight or pH after the delivery, or days to delivery from the diagnosis to the prolongation of the pregnancy is changed depend on the value of these markers. Another one, its first step in this study, we discover that it has also important for the prediction of neonatal outcome. Of course, if we compare independent of the gestational age, this change is slightly different. But if we look only on the woman before 32nd week of pregnancy, and we evaluate the preeclampsia with the higher or lower slit PLGF ratio, we also observe the adverse outcome in neonatal was worse if the angiogenetic markers was higher. That's another one very most potential method to the prediction of the complication. This year, we are going to present our experience, almost 2,200 patients between 18 and 40 weeks of pregnancy. And look, we discover in this cohort that if we have the over 300 slit PLGF ratio, this was almost 80 cases, the almost all delivered before 37 weeks of pregnancy. If we look on this typical cutoffs, that's over the 85 slit PLGF ratio, 80% delivered before the 37 weeks of pregnancy. And again, this above the 300, almost all deliver before 37 weeks of pregnancy. Only one method of diagnostic show us what the results of the perinatal outcome we get. So another one that's very interesting, our manuscript, that says that show that using the slit PLGF ratio, we can maybe not predict, but it is connection between these results and the neonatal weight. Look at this one. That was all baby who delivered below the 10th percentile. after delivery. And we discovered that if we observed the angiogenesis disturbance, this baby was smaller than if we have normal angiogenesis markers. And this was the one of the approach to the truffle study, which this was not only our study and our results, many other scientists conducted this direction observation, and this truffle 2 opened the new arm in this study, include also biomarkers to penetration and to the study of truffle 2. And now I would like to present some of the cases where and how we use the biomarkers in our practice, in our working day. So one case, patient with clinical symptoms. Look at this, the pregnancy with the pre-gestational diabetes, that's over almost 20 years. That's 20 weeks of pregnancy, really high blood pressure, proteinuria, no other deviation in the laboratory test, and normal angiogenesis markers. And what's happened? We changed the approach to the treatment. We changed the drugs, increase the doses, and add additional medication. We achieve stabilization of the blood pressure, slightly on stable proteinuria, and we conducted this pregnancy up to 37 weeks of pregnancy. Although the first situation was not very optimistic. So another one case, look at this, the dichorionic diamniotic pregnancy, 27 weeks of pregnancy, very high proteinuria and but no hypertension in the first moment. Slightly increase the uric acid and abnormal angiogenesis markers. 2 days after admission, high blood pressure, respiratory insufficiency, and of course C-section. After that, typical HELP syndrome. So according to our diagnosis, we could predict complication in the next couple of days. Another one that's slightly more sophisticated, we start from the beginning of the pregnancy. That's a very difficult case. That's why I would like to present you I describe as an antiphospholipid syndrome. So patient with the history in miscarriage in the 20 weeks of pregnancy, very hard and chronic diseases, history with thrombosis. So she was admitted in the 16th week of pregnancy. Unfortunately, no preeclampsia clinic and very bad symptoms, very high blood pressure, very high proteinuria. This means very bad prognosis. Look like the ultrasound uterine arteries, how look like the placenta, and abnormal, absolutely incredibly bad results in the sweet PLGF ratio. And of course, finally, the intrauterine fetal death in 90 weeks of pregnancy. So this present the diagnosis placental insufficiency very early. So that's a very long history for this lady. And finally, look, that's a prediction in the first trimester, how low was the PLGF. And this allows us from time to time to find very worse, very bad situation first. And another one, from time to time, implement the prophylaxis with the aspirin. I will not concentrate today on this because we have the limited time. And I would like you, sorry that we have to move quicker. Look at this one. This is the very interesting case, the last one. Oh, yeah, good. So 43 years old, second pregnancy. History with the first pregnancy, HELP syndrome in first trimester, of course, after the using the algorithm, we have the high risk of the pregnancy. In the second trimester, only abnormal uterine artery, mean pulsatility index above the 95 centile, and normal split PLGF ratio. Yeah, that's a 10. 2 months later, slightly increase. 1 month later, above 110. And 2 weeks later, increase again. That was 150. Wait a minute, 150, and we sent to the hospital. So 1 day later, we observe also the small deterioration of the growth velocity, and we get the next day CTG deceleration, and finally cause the transverse fetal position C-section. That allow us to make the deeper in the situation inside the uterus, inside the pregnancy, inside the placenta. And of course, the new manuscript from Jagel and in ultrasound obstetric gynecology, 2 types of the pregnancy, and definitely we agree. We couple years ago we presented our names which is strictly delegate to the ischemic of the placenta, according to many pathogenesis, the process who goes to the unfortunate, wait a minute, to the disturbance in the endothelium and clinical manifestation. And we ask, because we presented this manuscript this year, where we should include also diagnosis the preeclampsia, all cases before 20 weeks of pregnancy. Because if we look at the first type of the preeclampsia, according to this manuscript, definitely all cases before 20 weeks should be included to type 1, the preeclampsia. That's the details of this manuscript. Very interesting issue. That's after the preeclampsia, that should we concentrate on this high-risk group for Professor Baski Tilaganathan. That's very interesting, and we should implement also in our country. And finally, I would like to invite you to the Krakow. That will be the EPCOC Congress on May. Many famous keynote speakers. We have also preeclampsia session where we present our experience. Thank you very much.